Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy, and this episode is sponsored by Kelly Seed PharmD, an oncology education company for pharmacists. Today we've got a lot of FDA. FDA's been busy in the month of May, so let's get right into it, talking about some updates for BCL2, BCL2 inhibitors. I want to say BCLT2, but no, just BCL2 inhibitors. I'm saying two too often because now we have two BCL2 inhibitors on the market with the approval of Sonrotoclax, brand name Becalzi, and of course there's a Q then an A. The only time this happens in the English language, Q followed by A, is for drug names. So Sonrotoclax is a BCL2 inhibitor. It's the second one approved. It is a little bit more potent than venetoclax in the lab, causes more cytotoxicity, and notably has activity against the G101V mutation, which confers resistance to venetoclax and prevents venetoclax binding and action. This approval is in the relapsed refractory mantle cell lymphoma space after 2 lines of treatment, one of those being a BTK inhibitor. So it's third line for mantle cell lymphoma. The approval is based off of 103 patients with objective response rate of 52%, median duration of response of like about 16 months. So pretty good responses, pretty durable responses. But I think, we're kind of interested in Sonrotoclax beyond maybe just the mantle cell lymphoma space. The drug does need to be taken with food and water. Taking it with a low and high fat meal increases exposure 50 to 100%, so 1.5 to 2x if you're with a low or high fat meal. So it does need to be taken with food. There is, similar to venetoclax, quite a detailed ramp up that I'm going to go through. And just the take home point here, it's complicated. It's going to come as a pack that's going to be very clear what days you take what. So week 1, you take 1 milligram for 3 days, then 2 milligrams on the next 4 days. Week 2, 5 milligrams for 3 days, then 10 milligrams, then 20 milligrams, then 40 milligrams, will be in week 3, and then 80, and then 160 milligrams, and the final dose starting in week 5 and beyond is 320 milligrams daily. The highest dosage form is 80 milligrams, so it's still a fairly high tablet burden. At this point, we have seen with new pharmaceutical formulations that after the drug is approved, gain some market share. The company maybe reinvest to develop a more convenient dosage form. So I would not be surprised if years from now we have a 320 milligram tablet of Sonrotoclax. But for now, we have to make do with 1s and 5s and 20s and 80s, I think. 80s the highest. Similar to venetoclax, not a lot of big concerns in the label except for myelosuppression, tumor lysis syndrome, embryofetal toxicity. Doesn't appear to be big side effect differences between Sonrotoclax and venetoclax. We have the same drug-drug interaction potential with CYP3A4 inhibitors and inducers. Strong CYP3A4 inhibitors are contraindicated during the ramp-up. A strong inhibitor like itraconazole increases the AUC of Sonrotoclax by 11-fold. Posaconazole increases exposure by 13-fold. The dose reduction is suggested to be not from 320 milligrams to 20 in the presence of a strong 3A4 inhibitor, and then 80 milligrams in the presence of a moderate 3A4 inhibitor like fluconazole. So we are pretty used to dealing with these drug-drug interactions with venetoclax. We do have much more. Actually, in the drug-drug interaction route, we really have a plethora of drug interaction information with posaconazole and other 3A4 inhibitors with venetoclax. We're quite blessed in the venetoclax space. Certainly less information with Sonrotoclax here as a new drug that is approved as an accelerated approval. Staying in sort of this space here, we're going to talk about on 5/13, same day Sonrotoclax was approved, big day for BCL2 inhibitors. FDA approved the combination of venetoclax with Inqovi, which is the brand name for the oral version of decitabine, which is a hypomethylation agent, combined with cedazuridine, which is a cytidine deaminase inhibitor, which you need to be able to absorb decitabine. So this is now, and that approval is for AML. So it's the HMA-VEN approval for AML, so 75 and older or unfit for intensive treatment. So it's now an all-oral regimen. And so these patients, before, if they're getting HMA-VEN, would have to do either infusional decitabine or IV azacitidine. And so this allows them not to have to come into clinic. It allows, say, private practice groups that don't have access to infusion centers to manage these patients. It'll be a specialty pharmacy that they'll have to do. It's a standard dosing of both agents. I do think it's going to be a pretty popular regimen to be used. And certain patients, financially might benefit depending on their prescription drug insurance versus their doctor's office-based insurance or infusion center and how those are paid for. But it is going to change the space in AML, I think. You'll certainly see fewer of these azacitidine infusions now that we have this combination approval. Folks may have been doing this before, but I doubt it. Okay, so that's the BCL2 inhibitor portion of the talk. A lot of listeners to the pod tune in because they're new to oncology. They're trying to get up to speed with all the approvals like FDA is going out right now. All the information, they want quick weekly updates to help keep pace with everything. Well, if this sounds like you, check out the Oncology Insights newsletter, a free weekly email from fellow Oncopharm Kelly Karlstrom, founder of Kelly C PharmD and the ELO Collaborative Program. Each week she shares practical pearls, ways to think through oncology concepts without just memorizing guidelines, as well as insights on staying motivated and growing in your practice. It's written by a pharmacist for pharmacists, and it's easy to read. You can sign up in the link in the show notes for free. Okay, from BCL2 inhibitors to HER2 inhibitors. Zenoctuzumab, brand name Bizengri, so this ends in NRG Roman numeral 1, is an NRG1 fusion approved drug already for NRG1 fusion pancreatic cancer and non-small cell lung cancer. This approval is for advanced cholangiocarcinoma after first-line treatment. 22 patients were studied, 19 evaluated for efficacy, response rate of 36.8%. 7 of 19 had response. The 95% confidence interval for response is 16 to 62%, so quite a wide approval. Despite that, it is technically not an accelerated approval. The label has the asterisk for the approvals for pancreatic and non-small cell lung cancer, that they're accelerated approvals and further approvals contingent on a confirmatory study. That does not appear to be the case for zenoctuzumab for advanced cholangio. As a refresher, zenoctuzumab is a bispecific antibody binding to HER2 and HER3, and NRG1 fusion cancers secrete or have upregulation and production of the NRG1 ligand, which binds to HER2. So this drug blocks that HER2 ability to bind with its ligand NRG1, stopping the growth of the tumor. In the other NRG1 fusion positive space, the response rates overall for pancreatic cancer are 40%. In non-small cell lung cancer, it's 33%, so 36.8% certainly is in the ballpark there, although a very small n. T-DXd continues to impress. So we had 2 approvals for trastuzumab deruxtecan, or T-DXd. The first is that I'll talk about is Destiny Breast 11, which is the neoadjuvant dose where the control arm was dose dense AC times 4 than THP. So docetaxel, Herceptin, and Perjeta. So docetaxel, trastuzumab, and pertuzumab. So 4 cycles of dose-dense AC, 4 cycles of THP. That was the control arm. There were 2 other arms in the study. One was T-DXd times 8 cycles in the neoadjuvant setting. That did not get an approval. The approval is for T-DXd times 4, followed by THP times 4 in the neoadjuvant setting, which led to an improved pathologic complete response rate of 67.3 versus 56.3%. So better pathologic complete response by incorporating T-DXd in the neoadjuvant setting, but not just T-DXd. That was studied and was not as good. One of the few misses T-DXd has had, but it does still get an approval, changes standard of care, I think, in the neoadjuvant space by doing that for 4 cycles and then THP for 4 cycles. The second approval for T-DXd is in the adjuvant space for folks who have residual disease following surgery. This was the space where trastuzumab emtansine, or TDM1, had the early data. And so this is 16,000 plus patients with residual disease following surgery. Destiny Breast 05 randomized to either T-DXd or TDM1 for 14 cycles. The 3-year invasive disease-free survival improvement goes from 83.7% with T-DM1 to 92.4% with T-DXd. I think many folks were already wanting to do this after we saw how much better T-DXd was than T-DM1. Now we have this approval for sure, again, changes the standard of care. The last approval I will talk about was similar to what I've already talked about, like DestinyBreast11 on a prior podcast. I've already talked about IMvigor 11, which was adjuvant atezolizumab for muscle-invasive bladder cancer following radical cystectomy, where they tested them monthly for circulating tumor DNA using this new ctDNA platform called Signatera. And so they would test monthly, right? So they tested, and once they became positive for minimum residual disease, these patients were randomized to either atezolizumab or placebo. And so you see sign of the disease coming back. Obviously, atezo is going to be better than nothing. This is the case. We see a median disease-free survival improvement from 4.8 to 9.9 months. We also see an improved overall survival from 21 months to more than 32 months. So we are seeing some improvements here. It looks like we are seeing maybe some plateau in the DFS setting. I think the future of this space for muscle-invasive bladder cancer, when this study was done, it was in the air before many of these folks, only half got neoadjuvant chemo, for example. More patients are going to be candidates for neoadjuvant enfortumab vedotin and pembro up front, because it's hard for a lot of patients in the bladder cancer space because they're older and they're men and not so healthy to be candidates for cisplatin. More are going to be candidates for neoadjuvant enfortumab vedotin and pembro. What happens to giving these folks adjuvant atezo after they have rising ctDNA and after they've received pembrolizumab? So kind of a curious where that is going to fit in for folks who are having this positive ctDNA after pembro. The same is going to be true for this approval for T-DXd for folks who have residual disease following surgery, if they got a T-DXd based regimen like DestinyBreast11 for neoadjuvant. So we're always in oncology thinking about with how quickly things move, how quickly information comes out. Sometimes it's hard to apply that because the standards of care change so quickly. And so today, if somebody comes in and they're cisplatin ineligible, they're going to get enfortumab vedotin pembro before, hopefully, surgery. Now, that might is going to change probably to include cisplatin eligible patients too. So if those folks have rising ctDNA, they've already had pembro, do you do atezolizumab? That's where the approval is, but those data may not be applicable or generalizable to what current practices are going to be going forward. But that's oncology. That's why we love it. Thank you so much for listening. You can follow me on X at PharmDeepNet and follow the podcast other social media platforms at OncoPharmPod. And until I talk to you again, remember, doses matter.